welcome to the first Virtual Refractive Summit, webisode number 2. First of all, we want to thank to all our colleagues because we have received such a good teachings and such a good feedback from the last time. So we're very happy. We're proud to do something that you really like and enjoy. Today it's going to be even better because we have a lot of things. We have a lot of content. We have Dr. Ivo Ferreira with us, Dr. Ana Mercedes Garcia. Take a look to this OR. We have a lot of things. We're going to have a lot of simulation live surgery. Let's take a look. We have students, and of course, we have an amazing panel of key opinion leaders. Ivo, we have some surprise here. Tell me a little bit more about this.
I'm the one who's going to be, watching everything, learning a lot, and taking some notes. So please, if you have any questions, write to me. I'm going to be the one translating all your questions to some notes here. And we're going to have some questions in Mentimeter. There is a new platform that is going to be very nice to interact. So welcome, everybody, and thank you for being here with us.
So let's make this very interactive. As Ivo said, we want your feedback. We want your questions because we're going to be here for you answering, okay? So let's start with our first introduction. This is a journey. We started last week. We started last week with the first step, and now we're doing the second one. We're going to talk about techniques, Femto-Lasik, and Trans-PRK. The Virtual Refractive Summit, as you know, it's a disruptive and innovative online summit to reach your full potential in refractive surgery. As you know, I always say, it doesn't matter if you are an experienced surgeon or a young surgeon or a fellow or a resident. I'm pretty sure that today you will take home very useful tools, advices, and tips to put into your practice in order to improve your processes and results. I said, this is a journey, the refractive journey. So today we're going to talk about techniques. Next week, we're going to talk about customized laser surgery, and we're going to end the summit talking about the future of our specialty. It's going to be amazing, believe me, guys. So Ivo said, we are doing a survey in menti.com. Please, if you can go there, it's very easy. You just have to put this number, and we have some question for you guys. And then after we finish, we're going to see the answers, and we want to discuss with our amazing panel of today. Industry and academy, we love this. We truly believe that industry and academy, they have to work together to bring the best education possible. That's why with the Alcon Experience Academy team, we're working together. And I really want to thank Faustino Vidal for the help this week. Thank you, Uwe Morin, for your beautiful messages. And of course, Charmaine Levitsky, she's here with us. Charmaine, how are you? Can you hear me?
Hi, how are you? Great to see you. Thank you, Andres, for asking the Alcon Experience Academy to be one of the sponsors of this amazing series. I just want to say this is really great work that Ophthalmo University is doing. And I know the work that goes on behind the scenes, so I want to say a big thank you in advance to all of the translators. It's amazing that we have so many languages being translated at the same time. As well, it's an amazing panel. I just can't wait to hear from them and learn from them. And I know everybody is really looking forward to their pearls. So for those of you on the webinar today that want to continue your refractive learning experience, please come over to the Alcon Experience Academy. We have new modules launching every week. We have short video formats, 3 minutes, 4 minutes. And it's a free resource for you and your staff. So please come over and join us. And also, if you like what you see today, come back next week, tell your peers about it. We'll have 2 more left in the series, and we look forward to it. So thank you, and look forward to our refractive learning journey.
Thank you, Charmaine. Thank you for your kind words. Guys, if you take a picture of this QR code, you can go directly to the Alcon Experience Academy web, and you will find a lot of educational content. It's amazing. So, last week I was talking about generosity, the generosity of our speakers, and today I want to bring this concept, kindness. We have a dream team of refractive KOL, and they are here with us, sharing their time, their experiences, their advices. So let's talk about the kindness that they have with us. So thank you so much, guys. I'm going to introduce all of them very soon, but thanks for your generosity and your kindness. And if I talk about generosity, I have to talk about our translators. This amazing panel of surgeons that they are doing a great job. You cannot imagine how complicated it is to do a live translation. So thank you, Luz Marina Melo from Colombia, the great Cesar Villar from Brazil. Thank you, Cesar, for being here with us. Chiara Angeli from Italy, our beautiful Italy, thank you. And Konstantin Sherbakov from Russia. He's from the Alcon team of Russia. Russia, let me tell you guys, we have a lot of audience from Russia. It's one of the best country in Europe here with us. So congratulations, guys. Thanks for your support. I need to talk about these guys. They are supporting us a lot. Federico and Andres from Custom Surgical at Bionico Models. Thank you so much, guys. So today and during June in Custom Surgical, if you go to the web store, you can get a 50% off in all the products. But from now until the next 24 hours, you can get a 25% off if you use the MicroREC code 11. MicroREC 11, that's the code to get that 25% off. The same with Bionico models. You know, these are amazing, artificial eyes to do education programs and to practice your surgery. So get your 50% off if you use the Bionico VRS code. And after these all 4 webinars, we're going to have a special reward of $500 for all of you guys. Not all of you, just one winner. Don't worry, Andres, it's just one winner. So the Refractive Mentors community, if you take a picture also to this QR code, you can go to the Instagram account. This is the Refractive Surgeons community of Ophthalmic University. Follow us and be updated about all our activities. Well, Ophthalmic University and community, you know very well, we work with a lot of peers around the world. We love community, and the last weekend in Dominican Republic, we presented our new 4 basic pillars. We're going to work in programs inside these pillars. OU for knowledge, OU for growth, OU for connection, and OU for management. So stay tuned because we have a lot of surprises around these projects. Well, community, we are giving away a lot of scholarships. If you want to be here with mentors, online mentors, and physical mentors here in the Ophthalmic University campus in Mexico City, you can participate using the code YOVRS. We have partnership with different young ophthalmology societies like Jordan, Morocco, Uruguay, and Spanish. They have a special code you can see here on the screen. But if you know belong to one of these societies, you can use just this code, and maybe you can be one of the winners of the scholarship and spend 1 week here doing refractive surgery and learning about our specialty. A very special thanks to the Uruguayan colleagues and Mexican colleagues, because in Latin America, they are on the top of the audience here with us. So thank you so much, guys. Especially, I want to thank Dr. Bianchi Eberta from Uruguay, Javier Larcosana from Spain, Imane Tarib from Morocco, and Dr. Mais from Jordan. Thank you, guys, for your support. Well, that's it. I'm kind of tired of talking. So let's start with this amazing webinar. We are so proud and so happy because today we have a dream team. I'm saying the same because take a look at these amazing key opinion leaders. I'm gonna introduce first Dr. Arthur Cummins from Ireland, Dublin. Arthur, thank you so much for being here with us.
Thank you, Andres. It's my pleasure. It's my privilege. Thank you.
It's our privilege to have you here, and thank you again. From Portugal, Dr. Tiago Monteiro. Thank you, Tiago. Welcome to Ophthalmic University. It's also your first time here.
Yeah, it's true. Thanks. Great pleasure. Very proud to be here. Thanks for the invitation, and let's take profit of these new times.
Thank you, Tiago. From Russia, the lady of this team, Dr. Ekaterina Brancheskaya. Ekaterina, what an honor to have you here. Thank you.
Thank you for the invitation, Andres. I'm so glad to be here and hope this event will be as interesting as the first part, or more interesting.
Thank you, Ekaterina. Thank you. My pleasure. From Israel, David Smaja. David, also your first time. Thank you.
Thank you, guys. Yeah, it's a huge honor to be part of this dream team. And guys, I have to tell you that is fantastic what you are doing here. You take really advantage of this complicated period for humanity. And you guys know how to spread the education. It's fantastic. So I think it's a good time to tell you that and to thank you.
Thank you, David. Thank you so much. And a friend of the house, Dr. Francesco Carones. Tante grazie, Francesco.
Grazie, Andres. It's a pleasure. It's an honor. It's always something special to be here with you and participate to whatever you're organizing, because the way you're doing education is just great. It's just fantastic. So thanks again.
Thank you, guys. We are so happy to have you all here. So I'm going to go back for a while. I just want to show you again the code for dementi.com, please. As I said, we want to do this very interactive, discuss and talk with our speakers. So go there and answer our questions. So before we start, I want to show you guys, because we want to get to the summit, right? To the top of the summit. And we have a little journey to there. So let me, okay. We're here. Our way to the summit. What is this? Today, we're going to talk about the 3-pillar basic of this webisode. Then we're going to have the keynote of our speakers. We're going to have a live simulation surgeries with all this equipment. It's going to be amazing, guys. Then, of course, the discussion, evidence corners. We have 5 incredible minutes with Dr. Jason Pennycock. You cannot imagine how good is his presentation. And then, of course, the masterminds. Finally, it's a little surprise for our speakers. These are the 3-pillar basics for today. We want to talk about why and when perform LASIK surgery, like a Trans-PRK or Femto-Lasik. We want to know the patient and surgeon preferences. And of course, we're going to bring clinical cases, and maybe one of the most important things, the decision making. We know it's very important as a refractive surgeon. So, Dr. Arthur Cummings, we are ready for your presentation. If you are okay, we're going to start with the Trans-PRK keynote. It's your time, Dr. Cummings.
Thank you, Andres and Eva. And again, many thanks for this kind invitation. So I'm going to speak about Trans-PRK in 8 or 9 minutes, when and why. So these are my financial disclosures, and Alcon and Wavelight apply here. And the questions I want to answer in this talk is, when and why should I do Trans-PRK? When do I prefer another technique? What is my advice about this particular technique? What are the advantages to our patients and patient and surgeon experience? So I'm going to start just with a few facts about the corneal epithelium. So we know the corneal epithelium is normally very homogeneous, equally thick everywhere. But what if the thickness changes from the center to the periphery? And this slide is thanks to my friend Francesco. And the bottom line is, if you have a difference in thickness, the contact lens is acting, or the epithelium is acting as a contact lens. Thickness per se does not influence refraction, but a change of epithelial thickness does, if it changes from center to periphery. And if it's thicker in the center compared to the mid-periphery, you get a myopic shift, and the opposite, you get a hyperopic shift. So Streamlight is a product we started using about 2 years ago, and this is how we were told to do it. Put ice on the surface, do a PTK as deep as the thickest epithelium to the closest 5 microns, then take a 10-second pause, and then go straight on to the PRK, which with Streamlight is the wavelength optimized profile. And then again, put ice on the surface. And when we started doing this, we first looked at 20 primary eyes and 8 enhancements. And I wanted to specifically look at low refractions all the way through high refractions. So our lowest case was plano minus 150, our highest case was minus 1050, and the mean was about minus 450. And what we found was this, is that at 1 month post-operative, we were on average uncorrected acuity of 20/20 or better, and our best corrected acuity was almost as good as it was pre-operatively. And that seemed really impressive to me. If we looked at our refraction, we found that the sphere was basically eliminated. Astigmatism was down to 0.37, and the sphere equivalent had gone from -5 to nothing. And this I put up to show you the column of best corrected acuity. And at 1 month, almost all of these cases were at 1.2. So I was very, very impressed with our early experience. So I then did an analysis of these first cases against PRK. So 10 months after starting Streamlight, looked at the results against regular PRK. And what I found was at 3 months that 83% of patients were at 2016 for Streamlight and 92% at 6 months. So there was a definite further improvement between 3 and 6 months. In terms of uncorrected acuity, 85% were at 2020 at 3 months and 93% were there at 6 months. So again, this improvement over time. And refractive astigmatism, half of patients were around about a quarter diopter or less, and this increased to 63% at 6 months. And looking at predictability, slightly off at 3 months, but at 6 months, the numbers are small in this early analysis, but very, very much on target. And then when I compared Streamlight specifically to PRK, we found uncorrected vision was slightly better in the Streamlight group. Corrected distance acuity was very similar in the two groups. And manifest cylinder was actually slightly better in the PRK group. But this is all retrospective just off my internet-based refractive analysis program. And manifest refraction very similar in the two groups. So I want to show you why we start using it a lot now. It's just a patient who had a long checkered history with all sorts of things. I'll show you his corneal images in a moment. But we decided to do a Streamlight PTK, or a PTK rather, in August of 2018. And this is what his cornea looked like. You can see the irregularity in the cornea plus the subepithelial haze. And you can also see on this map in the center at the bottom, this thickened epithelium. And on the cross-section OCT, you can see just exactly how irregular the epithelium is. This is a map of the epithelium, thickened in the center. And then did a PTK, and you can see how the corneal clarity improved. And again, when you now go and look at the epithelial map or the OCT, it is far more regular. And in fact, the epithelial map now looks very much close to normal. And all we've done is a PTK. And when you compare this to the preoperative, you can see the massive improvement. And epithelium is always an indicator of how smooth the stroma is. So we know the stroma is a lot smoother in a complicated case after PTK. So I was very satisfied with all I'd seen. So we decided to do an IIT study at the clinic. And we had 30 patients with a contralateral eye study, looking at rate of epithelialization, PROs, especially reporting comfort, visual and refractive outcomes, corneal higher order aberrations, and epithelial mapping. And this was presented at ESCRS last year. And what we found is we first of all thought that TE-PRK would heal much more quickly, leading to higher patient satisfaction and a faster return to vision. I did not know at this stage which would be more comfortable, PRK or TE-PRK. And I didn't know on this particular platform which would provide the better results. So we did this study, as I said, on the EX500 wavelight. The two eyes had to be at least within 1.5 diopters of one another. And we studied the normal things one would do when you're doing a refractive study. These were what the results looked like. PRK is in blue and trans-PRK is in orange. And the truth is, based on sphere, on cylinder, on sphere equivalent, on uncorrected acuity and corrected acuity, and on Scheinflick data, we could not see a difference. There was no difference between the two procedures. And in fact, the only thing that was positive is that Streamlight was more uncomfortable on day one. It was more comfortable on day 3, but on day 1 it was more uncomfortable, which was, for me, was a surprise. So the conclusion was that both procedures were very effective and safe and predictable. Visual results were good in both eyes. Refractive results are very similar. And I think what's important to remember here is these were normal eyes with no previous surgeries. So yeah, in retrospect now, one would think that if you're removing a smooth epithelium with alcohol or with streamlight, it shouldn't make a big difference. In summary, however, I still see streamlight as being a very significant addition to the wavelight treatment menu, and especially in complicated eyes with irregular epitheliums, it's a fantastic tool. I want to just finish with a couple of papers. This is a paper looking at doing transepithelial procedures with wavefront optimized versus customized. And it appears that we get better correction of astigmatism if we do a customized procedure. And of course, with streamlight, we can do that. We can do the streamlight procedure with a very small quarter diopter correction, terminate the procedure or finish the procedure, and then do the topo-guided part. So you can combine it. And then in this particular paper, again, looking at transepithelial versus alcohol-assisted, and this group found the same as we did, that the first day PRK was more comfortable than transepithelial PRK. And in this paper, exactly the opposite. So it seems like the jury is still out in terms of comfort. What I do see is a faster recovery because patients were definitely more comfortable on day 3 than they were with trans-epi than they were with PRK. So to get back to my first slide, when and why should I do trans-PRK? Well, if you've decided to do PRK anyway for clinical indications, if you think there's additional value in doing additional smoothing of the stroma, you can't beat this procedure. When do I prefer another technique? Well, mostly just if I'm looking for a faster recovery. And obviously we all know LASIK is a faster recovery. And I found that EBK, PRK recovers very quickly too. What is my advice about streamlight, about trans-epi PRK? Measure the epithelium preoperatively and use ice before and during the procedure. It really helps post-operative control. What are the advantages to our patients? Well, it's a very psychologically safe procedure. Patients who are very nervous really like the idea that it's basically no touch. And then again, it is the best procedure I have for very irregular corneas. And patient and surgeon experience comes down to from a patient and surgeon experience. It's simple, it's straightforward, and it's very safe. So thank you very much for your attention.
We were taking notes here. You can see, I don't know if you remember in 2018 in your course, your fellowship course, we had a blackboard also. So I'm trying to do the same, Arthur, because it was amazing, that course. So we have some notes about comfort, predictable, faster recovery. I think that the final side was incredible. I don't know if the other speakers has some comments. Francesco, David, what about your thoughts? Francesco, you are on mute.
There, I think you can hear me now.
Yes.
All right, so excellent presentation, as always, from Arthur, no surprising, highlighting the importance of this new approach for doing PRK. I like particularly, as Arthur mentioned, the possibility for smoothing the cornea. I think this is one of the major advantages, and this approach turns PRK, I mean, a therapeutic approach, in a much more reliable and predictable refractive procedure. So more than on virgin eyes, I think that the greatest advantage that you will find doing transepithelial PRK are for those eyes that may be a little bit more challenging than routine cases.
Excellent. We truly believe that the effect of the non-touch surgery is very important for our patients. David, what do you think about it?
Arthur, thanks a lot for this talk. Always waiting for your talks during meetings, so I'm happy to have you starting here. It was great. My question for you is, it's a question that I think asked for many of the surgeons. When Trans-PRK came to the market, the first thought I think that it's a great technology, it's fantastic, and it's very comforting for the patient, because the patient feel that really the machine now has reached a great point of precision, and it's very nice, and feel very safe with that. On the side of the surgeon, I had at the very beginning some thought about a risk for overcorrection if you do not shoot perfectly well, and that's why it's very important to measure the epithelium before starting that type of surgery, because even though we have a window between 55 and 60 micron for most of the patient, I think it's very important in order to avoid some refractive surprise, to get that exam. And so I think it's one of the main point of your conclusion there. It was very important. My question is relating to the importance as well of what you said, the icing at the beginning, to cool the cornea before the surgery, because we know that the more you charge the cornea with some laser energy, the more you might increase the heat, and the more you might increase the chance of overcorrection. But I'm happy to see that the outcomes are very comforting here.
Yeah, David, you're right. You know, the PTK part almost always takes between 22 and 26 seconds. And you know, from using modern lasers, in 26 seconds today, you can do a -13 correction. So most times the PTK element is 24 seconds, the surgery part is 5 seconds, 6 seconds. So that does build up some heat. And it's the way Wavelight showed us when we first did it. And it's worked very well for me, and I've tried to keep that standard. So we still do Streamlight just like that.
Good. Ekaterina, Tiago, do you have some comments before we start with the live surgery?
Well, just
okay,
go ahead.
Let's go. Okay, thank you. Thank you, Arthur, for a very nice presentation. I would say about PRK, today in my practice, it's not a frequent procedure. For the last year, we performed it in 1.5 or maybe 2% of cases from all the refractive surgery in our clinic. And I would say about 1/3 of this PRK procedure is irregular cornea with scars, with RK. We have a lot of RK patients in Russia. I also do PRK in keratoconus patients after cross-linking or combined treatment cross-linking with the ring segment implantation. And of course, epithelial mapping is a very important question, but now we don't have, let's say, a good tool to do epithelial ablation in this irregular cornea. But I totally agree with you that when we smoothen the irregular stroma, then after the epithelial heals, we definitely have more regular cornea. And even if we have some problems like subepithelial regress, or so the stroma grows more regularly, and that's why we can deal with the problems like irregular astigmatism. And in our practice, we also didn't find any significant differences between scarification approach and transepithelial approach in consequence of when patients feel pain or they don't feel pain. So I agree with you.
Thank you so much, Ekaterina. Tiago, you wanted to say something.
Yeah, fast, just a couple of notes. I would highlight the sentence that Arthur said: epithelium is the mirror of stromal smoothness. And in the last few years, we have been amazed by the chance to measure the epithelium regularity and how this possibility has helped us in a lot of cases. Refractive surgery, corneal surgery, and even in cataract patients. So this is very, very important. Measure the regularity of the epithelium. So I would invite Arthur in 1 or 2 years to redo the study and make a comparison only with groups where the epithelium is more irregular without being a pathologic cornea. This is like this will be more like a contour PRK without having the topography guided ablation. I think we will have some chance to improve the corrected and the uncorrected visual acuity. And last, it's very unfortunate that we cannot still at this time combine the streamlight with a topography guided ablation. It's just wavefront optimized, but I think in the future, Alcon, of course, will offer us that chance. And this is for the pathologic corneas that Ekaterina was mentioning, which is very, very important also in our practice, to repair corneal disease.
Yeah, game changer for sure. So now Dr. Ana Mercedes Garcia will lead a live surgery. So Arthur, if you want to mentor our young surgeon that we have here, hello, how are you? He's from Mexico City, and she will perform a streamlight surgery. And we have here our professor, please.
Thank you. So let me introduce you, Angie. Angie is the first time that she will do a Trans-PRK surgery. So she's so excited and honored to have you as their teacher. So do you want to help her? Do you want me to tell her something special? We just taught her the basics, but I guess that you are the best professors that she can ever had. So Angie, so let's start. Dr. Cummings or someone else who wants to give any recommendations to Angie?
Yes, so I can't see. You have a patient in front of you right now.
Sorry?
You have a patient in front of you. You have a model eye.
The patient?
The patient, our patient, is a pig patient.
It's a pig patient. It's a pig eye patient, so, actually. This is live simulation, so no worries.
No
we
worries.
don't have a person here.
But I guess that's really important because we have to tell the patient what will he or her will feel, and so this is really important. This patient won't hear us, and it's easier for learning. But I guess that's part of the learning curve, to know that we have to tell the patients how will the patient feel and what we will do in the patient's eye. So I guess that's really important.
Exactly. And then the next thing you want to do is when you put the speculum in, I know you're not going to the pig now, but when you put the speculum in, try and use a speculum that has a full blade. And the reason this is important is you don't get all the meibum coming out into the tear film. And then something you need to remember is excimer lasers at 193 nanometers don't pass through water. So you can't have a wet cornea when you're doing the procedure. So you need to make sure before you start, make sure the eye is well anesthetized. You put some ice water on already, and then take a Wexel sponge that's wet and just smooth the cornea to make sure that whatever water might be there is equally distributed across the surface.
Okay, so Andy will start, and just to example what you just told us, Dr. Cummings, this cornea now is wet, and we won't have it this way because it won't be useful. So here we have the wet sponge, just a little bit wet.
Yes, exactly. And then just smooth it over and try and just make it look as smooth as you can with the Wexel sponge.
So that there's I don't know if you're able to see her hands and what we're doing, but okay, perfect. I know you can see her, and she's right now moisturizing or just using a little bit wet sponge. So the surface is the best way you can have it.
Yeah, so something important is if that's a human lying there, they've already had quite a few anesthetic drops. And with anesthetic drops, the epithelium becomes a bit soft. So I wouldn't brush quite as hard as you would there. I would take the soft edge of the sponge, like it's like a sweep, like a broom, and do it very gently across the surface. All you want to do is smooth it out as much as you can. If there's a few microns of water still on the surface, that's not a problem. It'll evaporate quite quickly. And while you lining up the eye, you're going to take some time and it'll evaporate then. But what you have in front of you now looks really good. So now what you want to do is tell your patient to fix on the green flashing light.
So we will tell our pig patient to fix on the light over him or her.
And tell the patient at the same time to make sure that for them, the green light is in the center of the 4 white lights. If the green
Perfect.
light, yeah.
So I think that's really important because sometimes we don't know if the light is green, white, what as patients, we don't know what to see. So as doctors, we have to tell them exactly what you told us, that they have to see through to the green light and be sure that the green light is in the center.
Exactly. The green light needs to be in the center because you know the tracker is going to follow the pupil, but the laser is going to treat the cornea. So even with modern fantastic trackers, you can get a decentration if you don't have the green light in the middle of the 4 white lights. So you want to make sure you see it that way, but the patient's also seeing it that way. So now you know you're properly aligned.
Perfect. So we will imagine that the patient just told us that it's centered. And do you want to tell me something else? Another tip before we start?
All we would do now, I would normally just tell the patient how long it's going to take. I'd say the total treatment is 31 seconds. There's going to be a break after 25 of 10 seconds so that they know exactly what to expect. And in the
perfect. So Angie, can you see through the oculars if there's the time that we will have with this patient? How many seconds we will be there with this patient in the
39.
Perfect. So you will tell that the patient, so he or her will know how much time we will spend in this treatment, and he will be a little calm, and he or her will know what we're doing. So after that, I don't know if you have another tip, Dr. Cummings.
No, then I just tell them, keep on looking at the green light. We're going to start now. And before we've even started, we've told them that the trackers are so good, they needn't worry about that, but they still want to look at the green light as carefully as they can. It's always very reassuring to tell a patient how good the technology is, and then they relax. You can see them relax about it. For many people, once they've got over the fear of the procedure, the biggest concern is not looking in the right place. So it's always nice when they know the trackers are so good. And then
Sorry.
No, I'd be ready to go then. I think you can start treating.
Exactly. So I asked just Angie to confirm the treatment with the outside pedal. She just did it. And now she's ready to do the treatment. Do you have any preferences if you hold the head or just the joystick, or what do you usually do in your regular practice?
So the patient's head is in the little cushion, so it's quite well secured. My hands are always on their forehead. It's a very nice thing with any procedure, with even cataract surgery, to have your hand on their forehead. It's very, very reassuring. Plus, it can help you keep it calm. So that's all I'd be doing at this stage. I see Angie has started already. It's looking good. We normally do this in darkness. I know the accuracy is fantastic, but I actually like seeing the fluence change when it goes from epithelium to the end of epithelium. So there's quite a high fluence in the epithelium stage. It's quite bright.
Okay, so we have the 10 seconds of interruption for the heat.
And then go straight on. Perfect.
Yeah, the time we have to wait for avoiding the heating in the cornea. And now we're doing the second part. I know this patient won't move, but it's important to tell the patient that try to keep watching the green light. And I think Angie is done. I was talking and she already did it.
That's fantastic. Angie, I can tell you your patient's going to be extremely happy. It was a perfect procedure, so well done. It's going to give you a lot of confidence.
Very good, Angie. Very good.
Thank you.
What a teacher you have, right?
Yeah,
well,
thanks.
We just finished our Trans-PRK. As you can see, this is a hybrid experience, a real hybrid experience, and we just have a real non-touch surgery, right? As Dr. Arthur just said, the patient is almost ready to go home. Thank you, Arthur. It was an incredible experience to have you here mentoring us. It's incredible. So the next part of the session, we're going to talk with Dr. David Smasha. David, are you ready?
I'm ready to share my screen.
Perfect. Thank you, David. All yours.
All right. So can you guys see here the presentation?
Perfect.
Okay, great. Okay, so my talk will be about the Femto-Lasik with the FS300 and how to master your technique for that. Those are my financial disclosure, and nothing is related to this talk. And the question first is, when I've been asked, even by my patient, when I do LASIK instead of PRK, but my question is more about when I don't go for LASIK surgery. And the reason is, when you compare LASIK surgery to any type of other refractive procedure, we can see in this very recent meta-analysis that LASIK can provide the highest predictability, better than any other surgery. It's fast recovery, it's the fastest recovery actually. People are very happy, there is no pain involved. That's a fantastic revolution in terms of ocular surgeries. So in order to answer the question, when I don't go for LASIK surgery, I apply what I call the top rule. Top rule is topography, ocular surface, and PTA. Topography, I just want to make sure, obviously, there is no suspicion involved with weaker cornea. Otherwise, I don't do any surgery, or sometimes you might have some irregularities, and therefore I go for PRK instead, mild irregular cornea. The second point, very important one, is I pay a lot of attention to ocular surface, and I make sure before LASIK, I don't have any dry eye that I have to take care of before. And I don't have any septal corneal dystrophy. I'm going to show you a case of patient that came back a few weeks after the LASIK surgery with a myopic shift of 2 diopters. And when you're looking at the epithelial map of the same patient, you can see this huge epithelial central hyperplasia that induced this myopic shift. I sent for genetic test, and I find this CBMD that we could not even screen it before with the epithelial mapping. And you can see another case report here discussing the PTK for EBMD after LASIK surgery. So if you don't want to get into trouble with the epithelial complication after the surgery, it's very important to track this very carefully. The last point is about the PTA. PTA is that we published that a couple of years ago already with my friend Marconi Santiago. PTA is percentage of tissue altered. You look at the flap thickness and the ablation depth, and you divide that by corneal thickness. We published our first publication on PTA was about the fact that PTA above 40%, it's a very robust risk factor for ectasia, even in cornea with normal preoperative topography, which means that even in normal cornea, you might weaken the cornea beyond its threshold of resistance, even in normal cornea. And therefore, when it's the case, I usually turn that to PRK. We publish a series of PRK because the PTA was too high. Obviously, as we saw also with the talk of Archer, outcomes are very good with PRK as well in high myopia. Now, in order to master really your LASIK surgery, I want to go over 5 pairs to make things always right. The number one is how to set your good start. And that's a very important point. I pay a lot of attention at the beginning on how to set the head and the chin of my patient. Number one is to avoid nose touch during docking. You can see here the difference between the head of this patient in the right position where you will have attached with the nose, and therefore you might have an incomplete docking. And you can see how just turning the head a little bit might clear completely the path for the PI. Number two is to make sure you have a good centration, and that's a very important point. And one of the things I find very useful in my practice is to make sure those 2 meniscus of conjunctiva have to be completely exposed. You can see here that I have just the upper one exposed, and in this part I have a very nice clear cornea that is well centered. So I always ask my patient to look at inside the ring, and this is a very good point to make sure that this ring that is illuminated is always located inside the pupil area. The second point is how to make sure you're going to have a nice docking. In order to have a nice docking, I always manage to have a decenter suction ring, and that's a very important point. This is the cornea of most of our patients. We have usually the pupil center and visual axis and vertex Purkinje. In myopic patient, most of the time this is confounded, and sometimes you have a little bit of cap angle, but most of the time the visual axis is always located nasally from the pupil center. And that's a very important point, because when you plane your flap and the excimer laser, the last situation you want to have is to have an excimer ablation that will cross a little bit on the edge of your LASIK flap. So this is a way of doing a nice docking. You can see I apply here the suction ring really adjacent to the temporal limbus. I have this nice creation of conjunctiva and nasal part. The vertex is perfectly aligned, as you can see here, and then you get a perfect and smooth docking of your patient. You can see here another series of patients. You get your suction ring slightly temporally. You can strike the cornea straight at the center of the visual axis, and then you just have to keep going down with your PI. So make sure every time you have this nice creation of conjunctiva to make sure your flap will not be too much at the temporal side, and you will have a very smooth docking. Now, the third part is how you can reduce your OBL. So OBL, we know from the literature, might be associated with too high energies because you have narrow channels that cannot advance enough bubbles. You have a docking with hard pressure, and even sometimes thecal cornea might be associated with OBL. So the issue with OBL is that you might have some incomplete flap lift and a kind of challenging flap lift because of the OBL. One of the things I find useful in my practice when you have that type of patient, just to go around the area of OBL, stay at the same plane, coming back toward the hinge, and never panic, take your time. At the end, you will get this right. So the channel that we start to do with the flap is always the first part of the flap being created. The channel is here to vent the gas bubble. The issue here is when you start to press too much pressure at the exit of your channel. It has been shown that the closest from the edge of the PI, the better you will have ventilation with your gas bubble. Now, look at this patient, for instance. You get this patient, you finish your docking, and that's the picture you get. You feel that it's too much inferiorly located, so you want to put that and recenter a little bit your flap. The issue with that is that, as you can see, the channel exits start to be too far from the PI edge. So it might be at this time submitted to too high pressure. So one of the great applications here with the FS300 is to use the channel adjustment flexibility. Your technician has to be aware of that, because at any time, as you can see exactly in this live surgery, I have an issue with my channel. So I ask him to press the plus button in order to extend a little bit, get a little bit closer from the edge of my PI. And this way you have a very nice, smooth flap creation with no OBL involved. Now, one of the challenging cases for all of us is most of the time is hyperopic LASIK, but to have them successful is really just about detail. Look at those two pictures. You have my eyes, which is emmetrop, where vertex and pupil center are completely confounded, and I have a nice flap here that can be centering both. But in hyperopic eye, most of the time you have high kappa with a vertex that is decentrated in the nasal part. And what we learned over the past years is that getting a nice centration of your hyperopic ablation on the corneal vertex is usually preferable because of this high kappa. But what you don't want to have is a mismatch between your ablation and the flap location. Look at this patient, for instance, where you have the flap nicely centered on the pupil, but not enough on the vertex, and you have your nice ablation, but unfortunately striking here at the edge of the flap, and you will have a lot of spot from your laser pulses striking not the stroma that has to be exposed, but the edge of the flap, which can be problematic for your treatment. So one of the things you can do to make sure you're going to have a good match between both is to increase a little bit flap diameter, obviously according to the white to white of your patient, but also according to the distance that you measure before the surgery with your topolizer between the pupil center and the vertex location. Let's say it gives you 0.3 millimeter, then you can just add that to the diameter of your flap. And this way you will have a very nice hyperopic ablation only going down inside the stroma that is exposed by your flap location. This is a picture of post-hyperopic ablation, very well centered on the vertex, as you can see here. So for hyperopic LASIK, the key message here is, number one, try to get larger flap, about 9.5, and make sure you get a full stromal ablation. You can check that with the Y2Y before when you set your flap diameter. Number two, try to get a thicker flap for deeper ablation in order to make sure the flap will not mold to the stromal shape underneath. You better have to recenter a stromal ablation between 75 to 100% vertex location, that has been shown many times in the literature today. Get your flap therefore more nasally so you can match with your stromal ablation. This is a very important point. And you might increase your optical zone because that has been shown many times as well, that your clinical outcome will be improved with that. Now, the last point is about the ability of customizing our flap. And we have this option of not getting a round flap. And the question is, why I would have a round flap when my ablation is completely elliptic, as you can see here? So most of my patient that has myopic astigmatism, I usually plan a flap according to the diameter in order to fit exactly the stromal ablation shape. And that is great because I don't have to get a big flap and I can save some tissue in those specific patient. So you can see here how nice and how elegant is it to get the full astigmatism myopic ablation right at the axis of my oval flap here. Now, look at this beautiful case that can be done only because you have the ability of customizing your parameter. So the message here is that this is the case of patient with a giant astigmatism on epikeratofakia. And when you have the ability to really customize your parameters, you can see that you really can push the frontier of your therapeutic possibilities. I have a lot of thickness here, which is also biomechanically neutral because we're talking about epikeratofakia. I have 9.5 diopter of astigmatism. And you can see here at the slit lamp, I just have to mark the epikeratofakia edges here. I have a little bit of scar tissue that I want to be outside of the flap area to make sure it won't interfere with the flap creation because it's too deep. And you can see here on the video on the left part how you can manage to get your flap down in such a cornea. You just have to load your ablation profile, which is here a topographic guided ablation. And this way, when you have that in overlay, you just have to adjust according to the side that you measure at the slit lamp and according to the ablation, stromal ablation you get, just have to manage to fit your flap size and flap diameter exactly to fit your ablation, your stromal ablation. In this specific case, I'm canceling my channel to make sure it will not interfere with the epikeratofakia in this case. And you can see here will be the flap position. I just press the button and then I have a very nice flap created within less than 6 seconds with a little bit of OBL here because of the cancellation of the canal, but the flap lift was pretty smoothly. And this is right after the surgery to see that the flap has been pretty good. So thank you very much for your attention and look forward for any question, guys.
Oh, thank you so much, David. That was a real masterclass of Femto-Lasik. I mean, it's amazing. If you want to learn something about Femto-Lasik, you have to go to YouTube then and watch this video. Thank you so much. Before we start with the live simulation surgery, I want to ask you, Dr. Carones and Dr. Ekaterina, is Femto-Lasik your preference technique? And in that case, can you give us some advices for the live surgery?
Sure. Well, first, let's say that Femto-Lasik is my procedure of choice in all the cases. I'm thinking pretty much like David was talking about. I do Femto-Lasik in all cases where I can, and I assign the cases to other procedures like PRK or phakic IOS or whatever, when I cannot do a Femto-Lasik in a safe and predictable way. That's my philosophy. Ekaterina?
Excellent. Thank you, Francesco. Ekaterina?
Femto-Lasik is also my favorite procedure. It is safe, and our patients also like the idea that they don't have a knife near the eye or microkeratome. Yes, I'm totally agree with Dr. David Smash that in a hyperopic patient, we have to be very careful with centering the flap and doing flap as large as possible. And I have one small question. As I heard, in a case with the epikertophakia, you told that you have 9 diopters of astigmatism, and we know that lasers that we use today, they do 6 diopters. Did you have a 2-step procedure, or how did you manage? Could you please tell?
Yeah, actually I did, because the patient has had a little bit of cataract as well. So I started with topography guided ablation. I could reduce to 4.5 diopters, and I completed with toric IOL cataract. It was a very nice case. Just show the first part.
I think the discussion that we are having here, it's pretty amazing. The audience, it's so happy. We have some notes here from the masterclass of Dr. Smaja. We talk about the set a good start. It's important, the head, the chin, everything. The descent a little bit for a good docking, the reduced OBL. We talk about hyperopic LASIK, so we have such a good advices. Now we are setting up everything for the live simulation surgery. We're trying to do docking, the docking. You guys just tell me when we are ready. So it's interesting because we have very good answers from the survey. Ivo, can you share the results of the menti.com? We're gonna see what the audience think about techniques, about the futures. So whenever you are ready, okay, we're sharing. Perfect. Excellent. As you can see, we have Femto-Lasik is the favorite. Yes, as most of the speakers. Excellent. Second one is the LASIK. I suppose this is microkeraton LASIK, and then Trans-PRK, PRK, and then Trans-PRK. So the next one. Let's see, what is the next question? Okay, this is very interesting, guys, because we have in one word or phrase, which are the barriers not to perform refractive laser surgery. And we can see training, fear, cost, age, money, knowledge, equipment, technology. Very interesting. Arthur, what do you think about this? These are the answers of the audience.
I think it's pretty good, Andres. That would be pretty much what I would think too. From my personal point of view, I'm always fearful of people with unrealistic expectations. And from a patient's point of view, for most of them, it's about fear. And once you can align those fears for them, then they're normally quite open about it. And they tend to proceed.
Yeah, the word here is training. Tiago, what do you think about it? I mean, we're here in a training center. I know you have fellows, residents. What is your thought about this?
Yeah, that's a very interesting point. Here in Europe, there are some restraints in training fellows in refractive surgery because most of these surgeries are done in private practice. So it's very hard to train our fellows in refractive surgery, and the learning curve is very, very steep and very long because of this very important topic. We only have 1 or 2 university hospitals where laser refractive surgery is available, so only a few have access to learning it. It's quite a challenge.
And the last one, you can keep answering this question, guys, the audience, is go to menti.com. You have the number, it's 555148892. That is the code, and you can keep answering because we want to have your feedback. Trans-PRK is the technique of the future. So, right? We have to keep waiting. Femto-Lasik adds safety and precision to the refractive procedure. Almost all the audience agree with that. And the last one is about the personalized refractive surgery is for all patients. So it's almost 3.5 the rate, right? Okay, keep answering. We still online with these questions. Now we have the live simulation surgery. Our big patient, it's almost ready. Ana, all yours.
Okay, perfect. So we have Jose Juan here, and it's his first Femto-Lasik. So we have done some steps before we get into live surgery. But one thing that I think that's important to talk about is that we have the option to get a bigger flap or a thicker flap. And that's one thing that we have to do in that, or a thing that we can do in the femtosecond laser, and it's a really great plus because we can decide if we can have a thicker flap or a bigger diameter flap. So that's important. So here we have the suction in the patient because we were having problems with this peak. He didn't want it to see through to the light, so we have to do it first. So we're going to start. I don't know if you want to give you some advice before Jose Juan starts the surgery.
I think it's pretty important to tell the patient before. I always take those few seconds to tell the patient before what he's going to experience, because there is few seconds pretty tense for the patient that he can't see completely dark for a few seconds. The patient has to be aware of all those things. So I'm always telling him that we are starting the first laser. There is 4 lasers involved in this LASIK surgery. And the first laser involved will take only about 20 seconds, the whole procedure. And he will experience some dark vision. Can you hear me?
Yeah, can you hear us, Ari?
Yeah, sure, I can. So I'm saying he can experience dark vision for a few seconds, and it's exactly the same that if he was putting his finger on the eye and pressing a little bit. So this is exactly the same sensation. So as soon as I'm getting close to the eye with the suction ring, I'm telling him again, this is exactly the moment I told you that you have to remember and you have to imagine you are pressing with your own eye on your finger, with your finger, and you will see dark for a few seconds. Don't panic, it's just for a few seconds. I think it's very important to have your patient with you here because, you know, that's a one-time surgery in life. It has to be very cool for this procedure. So that's number one.
And I think that's really important.
Is your pig hyperopic or?
No, he's not. He's a myopic patient.
That's good.
So I think that's important because many patients do not know that we have like what would the patient feel. So we have to tell them that he won't see anything for some seconds, that he will feel like some pressure. So that's really important. So now we can tell our peak patient that he is feeling a little bit of pressure and he won't be able to see anything for the next few seconds. And then I don't know if you're able to see our treatment screen.
Now I can. So at this point, before I continue anything, as soon as I have my docking, I'm just making sure I have no meniscus of tears here that can be threatening the procedure. It's very rare usually to have that with the FS200, but still, I'm always making sure that my docking is very stable and I don't have any threatening regarding possible loss of suction.
And I think that's really important. I'm sorry. I think that's really important because if we have a bad ocular surface, we won't be able to have a good flap because we can have a OBL. And so it's really important to have a great ocular surface and be sure that when we do the docking, we don't have any black spaces or black spots. So that's what I just told Jose Juan here. And I guess if you have another suggestion or tip or something, or we can go on.
One last tip for young surgeon. This is for young surgeon. This is the docking is usually the most stressful moment when you start doing LASIK surgery. If you get your docking and you are happy to be after the docking, but you see that the docking is not well centered, it's fine. Just cancel everything and redo the docking. Make sure you don't press the button and create a flap that is completely decentered, because the whole treatment after that might be completely offset. So it's fine. If you see that you have docking, it's not done yet, please stop everything, cancel everything, and redo that in a proper way.
Yeah, and I think that it's better to repeat the docking than to have a complicated flap or something that we can get like a really hard surgery. So I think that that tip is really great, and that we can re-dock the cornea and we won't have any problem if we haven't done any Femto-Lasik, so or any Femto procedure. So here we're ready, and I will ask Jose Juan to start the treatment. I think, I don't know if you're able to see what we're doing.
Doing pretty good.
So he's doing perfect.
At this time, I'm always talking to the patient. It's very important. We have 6 seconds. I'm always telling him, look, you are doing great. We're at the middle of the treatment. You have another 3 seconds to make sure the patient keep the position and does not move.
Yeah, and I think that it's important to tell the patient that with the bubbles and everything, he will be seeing even worse, or that he in that moment will see really dark. So the patient won't be anxious, and we can do everything in the correct way. So that's the femto part of the Femto-Lasik, which I believe it was really easy for Jose Juan. Do you have any questions or something to?
No, thank you.
What a great teaching session we have here. So next speaker, Dr. Thiago Monteiro. Thank you, David, for your advices. It's great. Jose, was good? You had a great teacher. Okay. The best teacher, yeah. We got an amazing flap, perfect flap, and that's thanks to the Femto technology. So now we want to move forward to the keynote of Dr. Thiago Monteiro. We're gonna do like a summary of all the things that we were talking until now. So Thiago, are you here?
Yep. Sharing my screen.
Perfect. Thank you, Thiago.
Okay, so I'm now going to do like a devil's advocate job, and we will try to sum up everything that was said here, and we will discuss it later after these slides. So we have been talking about surgical planning, and these are the very basics of corneal refractive surgery. We have been doing planning about surface ablation, PRK, especially the streamlight, which is a Trans-PRK, and we have seen how we do a primary Femto-Lasik procedure. It's nowadays very uncommon to use a microkeratome, and about retreatments is not part of this of my talk. So in the last 30 years, we have seen an extraordinary evolution in corneal refractive surgery, and these two pillars have driven the surgery to an outstanding level where we are today. Efficacy has been developed by the eye tracking, the new ablation patterns, the TCAT, the use of mitomycin C, and everything about epithelium management that we are learning today. Safety has been driven by the fact that we are now using a femtosecond laser to do the flap, because our preoperative screening methods are better than ever, and we are now screening tomography and biomechanics like we have never done before. So these efficacy and safety issues have taken us today, 2021, to a level of excellence where we don't know how we can improve it even further. So femto and surface, how to indicate? How do I do in my clinical practice? This is my 5 points that I discuss and study about the patient. So I make some biomechanical considerations and study the corneal tomography. I study that it depends on the type of refractive error, in the existence of other comorbidities like a corneal dystrophy, like David just said before. The indication for surgery, is this a pure refractive procedure, or is it also a therapeutic procedure? and clinical experience I have, and each of us has, and some geographic variations that we have to discuss also. So why the impact of corneal biomechanics? Because as we know, the laser has a considerable effect on the equilibrium of the cornea, and the thinner the stromal bed after surgery, the higher risk of postoperative ectasia. In fact, the problem is that we have difficulties still to predict the maximum amount of corneal ablation necessary that we have to take in consideration in order to prevent a secondary ectasia, and sometimes it's difficult to detect all eyes with preoperative undiagnosed corneal ectasia or corneal susceptibility. So David has mentioned before about using some risk tables, and one of these is the Random score, which is now more than 10 years ago was developed, taking into consideration the topography, the amount of residual stromal bed, the age of the patient, the corneal thickness, and the spherical equivalent to be treated. And I bring you a very small case, male, 28 years old, with a minus 4.5. He has a normal topography, but he has a 508 microns cornea. And if I do a Femto-Lasik surgery on him with a 100 or 110 flap, I could consider is 4 points, high risk. So would you go for the Femto-Lasik, even though there is a higher risk? Yes or no? Something we can discuss later. These are some of the risk factors that we have to consider for corneal ectasia. There are a very, very high number of them. Chronic high rubbing is one of the hot topics in refractive surgery. So avoiding ectasia is about assessing the corneal strength. And for this, we have the wonderful work of Renato Ambrosio and Vinci Guerra group, taking into consideration the tomographic and the biomechanical index. And we have to also assess the biomechanical impact of the treatment we are doing. And for this, I normally use the PTA, as David also mentioned. And I bring you another case. Regular astigmatism, female, 29 years old, -3 myopia and -2 seal on the right eye and -1.5 seal on the left eye. And this lady has a yellow spot on the bad D, but still the PTA is below 40%. Would we perform PRK? Would we do LASIK or something else? Extreme case. So, and this another one, quite different. 5 diopters with 520 microns on the cornea, and to consider a flap with 110 microns, we would be with 35% risk of if we consider LASIK. So the PTA value 35%, but if I choose a PRK, it goes down to 14%, and the bad D is perfectly normal also on these patients. So 3 patients, very similar, but also very different, maybe on their indication for surgery. So we have seen that really the femtosecond laser has driven us to a level of efficiency and safety with the LASIK regarding the microkeratome in all of these advantages that David just said. Most of them as a bladeless procedure, and the possible advantage in case of an ocular trauma of having a less risk of a flap dislocation. Also, the femtosecond laser has decreased the incidence of severe flap complications when we compare to the microkeratomes. And this is because we can customize the diameter, the thickness, the position of the inch, like David said, but also we can customize the side cut angle of the flap. And for me, this is very important because it really decreases the risk of epithelial ingrowth that we can have with a meniscus-shaped microkeratome flap. Even though last year, I had this very strange case of epithelial ingrowth in a primary femtosecond laser flap. As you can see, this is the image of the slit lamp of the right eye of the patient. No loss of corrected or uncorrected distance visual acuity, no trauma, no stria to the flap. And look how the OCT of the cornea can show me very perfectly the irregularity behind and the channel inside, underneath the flap, sorry. And small epithelial irregularity, but no loss of visual acuity. So even though we are performing a femtosecond laser, we can still have some complications. So we have new flap complications with the femtosecond laser. Some of them, as the OBL, we can go around them very easily, but the rainbow glare and the transient light sensitivity syndrome, which is more difficult to explain to patients where the medical treatment we have is also very scarce. So why should we consider surface ablation? Really, the new protocols combining epithelial removal with the excimer laser are here to stay. And most of the brands, Alcon, Schwinn, Bausch & Lomb, are really taking this very seriously into consideration. And I have to acknowledge that in the last 12 months, 48% of my treatments were PRK treatments. So I'm really a femtosecond laser and PRK surgeon, almost 50-50. And this sentence, I think, is very important, and it was already mentioned by Arthur. Really, these treatments were born together with the emergence of the epithelial mapping availability. So I return the question, why not always surface ablation? There are no flap complications. It's equally effective and safe in myopia and myopic astigmatism. We can correct small stromal irregularities, taking into consideration the epithelial mapping. There's, of course, less corneal biomechanical impact. There's less dry eye induction, at least in my opinion. There's a low risk of corneal A's when you use mitomycin. It's indicated for less cooperative patients. It's less expensive and also has therapeutic applications. And my good friend Fernando and the group of Renato has already proved that the PRK surface ablation can also be applied with complex ablation profiles, like in this very excellent paper presenting the Contura treatment with PRK. And as mentioned before by Dr. Ekaterina, the surface ablation is also a very important tool when we are dealing with therapeutic and irregular astigmatism. And here, of course, the epithelial mapping study is also crucial. So why not always the surface ablation? Because there's a slow visual recovery, there's pain after surgery, and patients don't want pain sometimes. It's less effective in hyperopia and hyperopic astigmatism. And we might also consider that in some clinical contexts, this could be a less commercial or sellable procedure, or even we might think it has a more shared time with the patient. And I show you here one of my last cases where I thought I should have done a femtosecond laser. Is a -3 male, which I done surgery in January 2020. And in March 2020, almost 3 months later, vision was still very blurry. And as you can see, the epithelial mapping is completely irregular. And only 6 months later, in July, the epithelium got smoother and the patient got 20/20. So I had to share time with this young male for almost 6 months, explaining that everything went well, and I really didn't have any explanation for the situation. So it's not always as we want it to be. And of course, corneal A's is always an issue in surface ablation, although it is very, very rarely seen nowadays. So I leave these 5 questions to the other colleagues of the panel. How do we indicate femto and surface? And we have a lot to discuss, I think. Thank you very much.
Amazing, Thiago. Another incredible talk. And we were discussing here with Ivo and Anana. I think we have this, one of the most important things here is the decision making, guys, right? I mean, it's about the patient, it's about the surgeon. Thiago said 5 questions, and I want to know the opinion of Francesco again and Ekaterina. What about this, the decision making? What do you have to do when we have a patient with a thin cornea, with a high keratometries? How do you work with all those patients?
Well, Andres, you know, it's all a matter of challenges that the surgeon wants to take on a specific case, because if you're going to ask the patient, what would you prefer to have, a PRK or LASIK? I would say that 99.9% of the patients would just say LASIK, please. So when you face cases where LASIK is not, I'm not saying contraindicated, I'm saying not an easy choice. There may be a challenging cases, it's very often it's a matter of taking a decision in a way for maintaining and respecting the highest level of safety, but at the same time not really cutting off the possibility for the patient to undergo laser refractive surgery, because nowadays, and I think it's a common finding from everybody, when patients are told you cannot have LASIK or it is better for you not to have LASIK, they may turn out being and saying, well, let me think then, because I don't have time enough to take that long recovery time that may happen sometimes. And obviously, in most of the decision, it's not either white or black. So sometimes, as I said, it's more a matter of where do I want to stretch the limits? Where do I want to compromise the 100% of confidence that this procedure is the most adequate one? I think that femtosecond lasers really changed the risk of having ectasia. In other words, obviously, over these years, we learned a lot as regards the challenges of ectasia related to all the factors like thickness, like the percentage of tissue treated and all of that. But at the same time, the accuracy and the consistency of the flaps that are possible to achieve with the femto laser actually made the variables much smaller. In full honesty, I had cases, as everybody, of ectasia when doing microkeratom driven flaps. I cannot remember a case of an ectasia since I started using the femtosecond. And needless to say, I got more and more cautious, as most of the parameters went, evident that some of the factors would lead to ectasia. But at the same time, I think that the consistency of a flap taken with a femtosecond in terms of thickness led us to be much safer than with mechanical microkeratomes.
Agree 100%, Francesco, thank you. And Ekaterina, Ivo has a great comment. What do you think about this thought, Ivo?
No, what I see in a new perspective is, for example, if I have this refractive suite, right? We were talking about the patient perspective and the surgeon perspective, right? They're completely different. And I like to see what other key opinion leaders in the world think, because I think basically the decision is, do I really want a patient that's going to have 1 week or 10 really, really bad days, but then forget completely about it? The ablation, it's in a segment that is not risky and it's completely different. Or as a surgeon, I do a Femto-Lasik and that patient is going to be 24 hours perfectly, happy and telling other people how happy he is, but I have the risk in the future to have an ectasia. I think that's one of the main discussions, right?
Absolutely. Ekaterina? Oh.
So I would like to share some tips about BAD, Bell-Ambrosio display interpretation. Today, so it's perfect if the eye hospital has both Scheimpflug camera and biomechanical examinations, but today not all eye centers have biomechanical examinations. So first of all, what I would like to tell about my experience with the keratoconus patients is that I put attention when I have asymmetrical astigmatism. I mean asymmetry both in between eyes, between right and left eye, and asymmetrical shape in between superior and inferior part of the cornea. And it's really, for me, it's really make sense. So the next tip I would like to share is if we have, for example, a borderline yellow marks at BAD, but if we see the indexes which are related to pachymetry and the eyes are quite symmetrical, so as I interpreted it, I suggested is a thin cornea, and I manage this patient in considering if the ablation, if the residual stroma would be enough for a flap creation or it won't be. And the next thing about PRK I would like to share is today we use mitomycin. In some centers it is allowed, in some centers it is not allowed. But still, yes, of course, it's a good tool. But even with the mitomycin, for the last year, I had 2 cases of mild, very small haze, and the patient were not happy. This haze disappeared by 1 year, but still there were some problems with discussing with this patient why they are not satisfied with their vision.
Amazing, amazing thoughts, Ekaterina. Thank you so much for sharing your experience. Talking about keratoconus, ectasia post-LASIK, and MBA. We have a short video about evidence-based medicine that we want to share with you guys. It's 5 minutes, and then we're gonna have the end of this amazing summit. Guys, whenever you are ready.
I'm Dr. Jason Fennicook, and today we're gonna talk about the best tools to climb higher and optimize the technology to your advantage. It's time for the evidence corner. In the evidence corner, we try to give you tools to climb higher and be able to reach that summit of refractive surgery that you've always wanted to reach. Today, we're going to talk about 3 things. Number 1, to keep your toolbox updated. Number 2, how each tool has a purpose. And finally, use your tools safely. Keep your toolbox updated. Imagine for a second that you're planning to go up a mountain. As you do your checklist and prepare your equipment and make sure that everything that you're taking has a purpose and that everything that you're taking is something that is useful for you. So today we want to remind you to keep your toolbox updated. What do we mean by that? In today's age in refractive surgery, we have different types of surgery, and you have to be constantly studying what's coming up, what are the new technologies, and how you can use those to the advantage of your patients. For instance, we start with PRK, and now we have Trans-PRK that has a faster recovery time and can even be touchless for those patients that are, more nervous or more anxious. We used to have LASIK, and now we have femtosecond LASIK, which has a shorter recovery. Once again, it's very comfortable and is a lot safer with less complications. We have other technologies like SMILE or LYRIC, that is laser-induced refractive index change. All of these technologies are things that you have to keep in mind and to keep in your toolbox, continually being updated so you can know what's the best option for your patients. Next, we want to remember that each tool has a purpose. When we talk specifically about Trans-PRK and femtosecond laser, we can remember that each patient has an appropriate tool where we can help them. For instance, patients with thin corneas or selected patients with suspected keratoconus, smaller refractive errors, or patients that get very anxious or have predisposed to retinal factors are best suited with a Trans-PRK technique. While other patients like millennials, patients that have a short window of time where they can have their surgery because of medical tourism, or have a lifestyle that's more active, or even have a bigger correction to do or a lower pain threshold, are ideal for femtosecond laser. Know your tools and know how each tool has a purpose and how you can take advantage for your patients. Finally, we want to remind you to use your tools safely. Using your tools safely is about remembering that elective surgery must be safe. Our patients are coming in for something that can be done at any given time, so you don't need to risk your patient in order to do one more surgery. Patient selection must be strict. Once again, there's no point of going ahead and doing a surgery to improve their vision and their quality of life if they're going to present some complications later on. As surgeons, we need to be humble and honest. Humble enough to tell the patient where their outcomes are not something that we can accomplish, and honest enough to be able to tell the patient, no, this is not a good procedure for you. Not all surgeries are surgeries that we need to do. Let's remember that surgery must be safe, and our tools must be used safely to be used correctly. And these are the 3 tools to climb higher that we want to share with you today. Keep your toolbox updated. Each tool has a purpose, and use your tools safely. If you would like to know more about the evidence that went into this episode, please reach out to me on social media at drjsn1. As I was looking for this information, I came across an interesting quote that I'd like to share with you today. This quote says, "Some mountains only require a good pair of shoes. Others require an entire toolbox to conquer. Knowing which is the key to success." Take care.
Okay, that was the great Jason Penico. What an amazing video. And I love the last part, talking about the humble. We have to be humble. We have to be honest with the patients. Dr. Cummings, what do you think about the last 2 words for the refractive surgeons?
I think he's 100% right. That was a super presentation. I really like it. And at the end of the day, we've got to do things that we've done for ourselves. And with elective surgery, it's got to go well. It's got to be safe. It's got to be like the airline industry. When you climb on a plane, you expect to land at the other side. And people don't take shortcuts. So I think that was super.
Thank you. Okay, guys, last 5 minutes. Please stay here because we have a little surprise for our speakers. And this is very emotional for us. We want to give you something that we think is important for you guys. Enjoy it.
It's a great honor to introduce and say a few words about one of the speakers, Ekaterina Branchevska. She's a very young but very highly sophisticated surgeon, but she's not just a surgeon. She's a young mother of a beautiful baby. She also plays tennis and dance breakdance. And a great honor to me that her first steps she performed at our institution. I wish her good luck and a great future in ophthalmology.
Hi, I am Renato Ambrosio from Rio de Janeiro, Brazil. I'm very happy and grateful for being able to say a few words about my colleague and friend, Dr. David Smadja. I know David since he was a fellow at the Cleveland Clinic, and congratulations, David, for all your great contributions. I know there is much more to come. Also, thank you very much for the great work and the collaborations with the International Society of Refractive Surgery for the externship. This has been great. Thank you very much for all your work. And I just want to say that you are the definition of the refractive surgeon scientist. Congratulations, and look forward to seeing you all soon.
Hello, my name is Luca Vigo, and have been working with Francesco Carones since 1995. Francesco, first of all, is a great friend and a wonderful colleague. He's very passionate about his work and passed on his passion to me. All I know about refractive surgery is because of him. So thanks, Francesco, for being a friend of mine and for teaching me day by day your experience. Thank you very much. Ciao, bye-bye.
Hi, dear friends. I'm Filomena Ribeiro from Portugal, Lisbon, as you can see. And I am a big fan of your Ophthalmo University program. But right now, I would like to take you all to the north of our country, Oporto wine lands. I would like to present to you Dr. Tiago Monteiro. He's a very good friend and a cataract and refractive surgeon expert, and likes also very much to teach. So looking forward to be with you in this virtual refractive summit. Have a nice meeting, and I will be there. Bye, friends.
I am Roger Saldivar from Mendoza, Argentina. It's my great honor to thank my dear friend Arthur Cummings, Arturito. Thank you for all your contributions in ophthalmology, but most of all, thank you for being such an inspiring doctor for all younger generations. We all learn so much from yourself. You are so humble and so nice to share experiences and everything. So I have been very lucky and privileged to have the opportunity to be in the same path with you in many places, and I would always be thankful for your friendship. Thank you very much, my friend.
Well, this is a little gift from Ophthalmo University and the Icon Academy experience for you guys. Hope you like it. We are finishing. Before you have the last words, Ivo, you want to say something? And also,
no, guys, I want to tell you that this machine, it's here. It's in Mexico City. It's for you to learn. Meche is here with us. She's one of the best teachers ever. So everyone who wants the dream to become a refractive surgeon, we're here waiting for you.
Well, this is the Ophthalmo University team. Charmaine, before we finish and our speakers say the last words, would you like to say something? We had an amazing webisode again.
No, congratulations, another successful event. Thank you to this amazing panel. We've all learned so much on our refractive journey, and I'm really looking forward to next week. Thank you so much.
Of course, see you next week. Arthur, last words, or Arturito, as Roger said. Little Arthur.
Listen, well done. You guys have done an amazing job, and I'm so pleased you have. You know, every time I look at the WHO, we look at the visual impairment globally. The biggest problem is always uncorrected refractive error. And the fact now that you are teaching people to become refractive surgeons is fantastically useful. And I couldn't thank you enough. I mean, our generation should be the one that changed the course of humanity. And we were good ancestors to the people who come after us. This is a good time to have a visual error because we can fix it so well. So thank you guys all very much. It was superb.
Thank you so much for being
here.
Can you hear me, Joe?
Bye-bye.
Tiago, are you there?
Yes.
Yes. We want to finish
with a last word from all of you guys.
I am currently booking a flight to Mexico, so prepare the fresh Corona beers. And as I was taught by Arthur, this is the time to bring refractive surgery to the highest level, and really education and learning from all people, from the youngest and the oldest, is the way we bring the refractive surgery to the highest level, and to give our patients the highest level of confidence in such an important treatment in their lives. So your job has been amazing. Thank you.
Thank you, my friend. This is your house. Come whenever you want to be here in Mexico. Ekaterina, thank you so much for being here.
Thank you, guys. You are really a great team. I think I would like to wish all the best to Ophthalmo University. This is an amazing job you do to help young specialists to find their path.
Thank you, Katerina. Thank you so much. David, it was an honor to have you here for the very first time in Ophthalmo University. Thank you.
Guys, that was great. I think you guys deserve a fantastic thank you for the organization and for the things you are doing. I will certainly come with Tiago. Just don't want you heard about Corona anymore, so you will have to find another beer for me. But just a few words about what Arthur Cummings said. He is not here anymore, but I think what he said is extremely powerful. taking advantage of fantastic technologies such as refractive surgery today for the rest of the humanity, because we know that the weight of the refractive error in education especially can be, I think, the next mission of our generation. Trying to do humanitarian refractive surgery should be the way we should see our next decade in refractive surgery. Thank you, guys.
Awesome. Thank you, David, for your kind words. And Francesco, please, if you come to Mexico, bring some Italian wine. We're waiting for you. Thank you.
That's a good idea. Well, what can I say? What can I add to what has already been said? I mean, you're doing a wonderful job. These meetings are really amazing. That's the second time that I take part of, and I really value what I hear. I really value being with you. And if you hear my voice a little bit broken, this is not because of the internet connection. It is just because I was a little bit touched by the nice present that you as an organization gave to the speakers. So you are great, you are wonderful, and I really hope to be involved again in the future. So thanks again.
Thank you so much, guys. Now,
thank all the translators.
Yeah, the translators, of course. Yes, Luz, Cesar, all the team. You are amazing, guys. Thank you so much.
Team.
The audiovisual team, the Palm University team.
A big team behind everything.
Absolutely. Thank you. See you next week. Thank you.